Okay, our today's lecture is adrenocorticosteroids, or in the commonly we say corticosteroids, right? So, you know, there is a very important role of corticosteroids in the uh, clinical therapeutics, and today we are going to discuss. So, corticosteroids, adrenal glands. Adrenal glands have two parts: adrenal cortex, the outer parts, or adrenal medulla. Adrenal medulla, that is responsible to release epinephrine, norepinephrine, that is also called emergency hormones, right? And it controls the sympathetic activity. But we are going to focus today adrenal cortex, right? So adrenal cortex, the secretions responsible to control salt and water metabolic activity, right? And the sex hormones. Adrenal cortex salt the secretion that control the salt and water, that is mineralocorticoids, and the secretions that control the metabolic activity or sugar activity, that is glucocorticoids, also known as steroids, and sex secretions, gonadocorticoids, right? But our main focus would be on glucocorticoids, because why it is necessary to clear your concept, right? When we say corticosteroids, so we have different secretions. If we say corticosteroids, in which we have mineralocorticoids, glucocorticoids, gonadocorticoids, right? So specifically, glucocorticoids, okay, one of the part of corticosteroids, because already we have discussed adrenal cortex, responsible to release three different secretions. One of the secretion control salt and water, another secretion control the sugar activity, and the third secretion control the sex secretions or control the sexual activity, right? So today basically we are going to focus more specific glucocorticoids, right? So cortex anatomy, the adrenal cortex is composed of three zones or three layers histologically. Outer is labeled as zona glomerulosa, and that is the site for aldosterone synthesis. I think you are well aware of this aldosterone, because this is the aldosterone secretion which is responsible to control the salt and water activity, and this secretion controlled by renin-angiotensin system. Central zona fasciculator, that is responsible to release cortisol, and inner zona reticularis, responsible to produce androgens, right? And this is very important slide. There is a feedback mechanism. If there is anything increases the other secretion, control its further secretion. Hypothalamus is responsible to release corticotropin releasing factor, that is also called CRF, and this ultimately stimulate anterior pituitary gland, right? So anterior pituitary gland is in which we have adrenocorticotropic hormone, which is stimulated, and it will act on adrenal cortex and releases glucocorticoids, right? When there is increased secretion of glucocorticoids, there is a negative feedback, where negative feedback on anterior pituitary, where it inhibits the secretion of adrenocorticotropic hormone, right? Okay, because when there is excessive glucocorticoids, now there is a message towards anterior pituitary that there is no more requirement of glucocorticoids, so stop ACTH, right? And there is another negative feedback mechanism towards the center, that is the hypothalamus. So there is no need to release corticotropin releasing factor because we have enough glucocorticoids in this equation, right? So these are the negative feedback mechanism. So again, this already we have discussed. There are different layers of adrenal cortex. So zona glomerulosa, the outermost layer responsible to release aldosterone, and zona fasciculata, the middle layer responsible to release is glucocorticoids, in which we have different secretions: cortisol, cortisone, and corticosterone. And the last layer, innermost reticularis, responsible to release sex hormones, in which we have androgens and estrogens. So this is all about the cortex. And already we have discussed, we are going to focus on glucocorticoids as well as mineralocorticoids. So glucocorticoids, cortisol or hydrocortisone. Cortisol is the prototype secretion of this group, and the kinetics of this group is it is well absorbed orally and bound to transcordin, that is the plasma alpha globulin, and also bind with albumin and distributed all over the body, and it can also crosses the blood-brain barrier. In the liver, this is important how it's going to get metabolized. In the liver, cortisol is reversibly converted to cortisone and conjugated with glucuronic and sulfuric acid, right? It's created in urine as 7-hydroxycorticosteroids. So this secretion, this metabolite 7-hydroxycorticosteroids, has clinical importance if you want to check the level of blood level of or overdose of glucocorticoids. We can also check the level of 7-hydroxycorticosteroids in urine. Dynamics, pharmacodynamics, in which we have two subheadings: mechanism of action and pharmacological effects. This mechanism of action is important from the exam point of view because this is one of the point that is asked in the exam, how through which mechanism of action glucocorticoids they are going to produce its activity. Corticosteroids passively pass to the cytoplasm, where it binds to mobile cytoplasmic receptor. The mobile cytoplasmic receptors, or this corticosteroids or cytoplasmic receptor complex, that will enter into the nucleus and will bind to nuclear response element, and increasing or decreasing messenger RNA, which in turn control the protein synthesis, giving rise to the cell response. So in short, we can say that the site of action, that is the at which site, at the receptors, the receptors for the glucocorticoids, they are located on the cell membrane, in the cytoplasm, or in the nucleus. Your answer would be in the nucleus. So in the nucleus, corticosteroids, they are going to produce its activity. This is important because what we have done up till now, the normally the drugs bind with the receptor which are located on the cell membrane. This is one of the option. The second option could be the drugs, they are going to bind with transmembrane receptor in case of insulin, and there are some receptors which are located in the cytoplasm, and there are some receptors which are located in the nucleus. So this is very important conceptual point. That is why I am explaining it, because there are different sites where receptors are located and where drug binds with these receptors and elicit a response. One of the location is the cell membrane, another location is the transmembrane, the third location is the cytoplasm, and the fourth location is the nucleus. And corticosteroids, one of the example that produces its activity at the nucleus level. Clear? Now the pharmacological actions, and now these actions are very much important because if we say the pharmacokinetic of any drug, uh, how the drug is going to get absorbed, metabolized, and eliminated through the body. In dynamics, we basically uh, explain the mechanism of action and the pharmacological action of that drug, right? And these actions, uh, sometimes beneficial, sometimes they are harmful and showing the adverse effects, right? So, number one action, pharmacological action, increase glucocorticoids. They are going to increase blood sugar. That means they are going to produce hyperglycemic state. So when we are going to discuss the pharmacological actions, at the same time I will explain to you or try to correlate it clinically, right? So how it's going to increase the sugar level or hyperglycemic state? By increasing glycogenolysis process or gluconeogenesis process. So these are the process will lead to increase blood glucose level. So it will produce hyperglycemic state. So how we can correlate this action of glucocorticoids clinically? In which condition? Diabetes, right? If a patient is diabetic, so we'll have to be very, very careful if we are going to start glucocorticoids, right? So because it will increases the sugar level. So that is why if we have to start the glucocorticoids in diabetic patients, sometimes it's very difficult to control blood sugar level in that patient. Okay, the second important point is the increased protein synthesis. तारिक एक मिनट यहाँ पे योर स्क्रीन शेयरिंग इज पॉज, मैंने कुछ क्लिक किया था, ये मैसेज आ रहा था ना, ये कैसे दोबारा वो होगा? Okay, sir, sorry. Okay, the second point is the increased protein catabolism. That means breakdown of protein resulting in growth retardation in children and osteoporosis in adults, right? And one of the mechanism which is involves in osteoporosis, that glucocorticoids stimulates osteoclastic activity, right? Bone resorption activity, and inhibit the osteoblastic activity, right? So that will lead to osteoporosis. Okay, increase deposition of fat, especially in shoulders and on backside, right? So that is the condition that is called buffalo hump, and on face that is labeled as moon face, right? Sodium and water retention, resulting in hypertension and increased body weight, right? So glucocorticoids, they are going to enhance the salt and water retention mechanism. So if there is increased salt and water retention, increase blood volume, increase chances of hypertension, and definitely ultimately it will increases the body weight. Another pharmacological action is the increase RBCs and thrombocytes, right? So it will increases the viscosity of the blood, right? So when there is increased viscosity of blood, so there will be sluggish blood flow. So increase if a patient having a history of angina, so increased chances of myocardial infarction in that patient, right? Decrease lymphocytes and eosinophils, right? So one of the important uh, immune activity that is controlled by the lymphocytes. So when there is decreased lymphocytes, so that means immunity is going to suppress or decrease immunity. So increased chances of opportunistic infection, right? When there is decreased lymphocytic activity or immunosuppressive activity, right? So what will happen, right? What will happen? That is the uh, increased chances of opportunistic infection, right? And the next pharmacological action, if a patient is glucocorticoids, hypercoagulability of the blood. This also already we have discussed, because when increase RBCs and thrombocytes, increase blood viscosity, so ultimately increase chances of hypercoagulability of the blood. Okay, immunosuppressive, and this is very, very important pharmacological action and has a strong relationship with clinical therapeutics, right? Immunosuppressive, how? Because it decrease antibody production, T lymphocytes, eosinophils, monocytes, macrophages, and neutrophils. Okay, so how we can correlate this immunosuppressive property of glucocorticoids? And very important, this pharmacological action having very important clinical application or clinical correlation. How? One of the example is, if you are going to, if a patient having autoimmune disease, one of the example is the rheumatoid arthritis is one of the important example of autoimmune disease, uh, Crohn's disease, ulcerative colitis, right? So in these conditions, because immune cells are selfly detecting the uh, human body cell as a foreign body, right? And they are activated against the own cells, body own cells, right? So that is why autoimmune disease, right? So they are going to uh, destroy the structure. If we say in case of rheumatoid arthritis, so inflammation of the joints and there is swelling, pain. So in that situation, we can use glucocorticoids to suppress that immune cells activity. Clear? And second, very important example is the transplantation transplantation or transplantation of the organs. So if we are going to transplant organs in any other person, first we'll have to suppress the immune activity. Otherwise, transplantation rejection can occur, right? So at least you must remember these two important examples of clinical application of this immunosuppressive ability of glucocorticoids. But at the same time, this immunosuppressive activity, how it's harmful, because if we are using glucocorticoids due to immune suppressive activity, already I told you, increased chances of opportunistic infection in that patient, right? Okay. So next property is the anti-inflammatory property. Again, this has very strong clinical correlation, because if there is a process of inflammation, and this glucocorticoid supposed to be the most powerful group to inhibit the inflammatory process. Corticosteroids inhibits prostaglandin synthesis, leukotrienes, interleukins, and platelet activating factor synthesis, inhibit migration of leukocyte to inflammation area, and stabilization of the lysosomes, right? And in the one of the lecture of the NSAID, non-steroidal anti-inflammatory drugs, already we have discussed. If we just try to recall, lipid bilayer is responsible uh, to produce arachidonic acid with the help of an enzyme that is called phospholipase A2 enzyme. And this arachidonic acid is converted or enter into the two pathways. One of the pathways labeled as the leukotriene pathway, and one of the pathway is the cyclooxygenase pathway, right? So this arachidonic acid, if we block the synthesis of arachidonic acid, we can block the pathway of leukotrienes or prostaglandin synthesis through cyclooxygenase pathway. So all these are involved in the inflammatory process. So how we can inhibit synthesis of arachidonic acid? If we inhibit phospholipase A2 enzyme, right? And glucocorticoids, they are going to inhibit the activity of phospholipase A2 enzymes. Okay, anti-allergic activity decrease the response to antigen antibody reactions, increase acidity of the stomach. So this is one of the side effect of glucocorticoids. You know, one of the important clinical point that you must remember at this level, if a patient is on glucocorticoids, it's very difficult to control the glucose level if a patient having a history of diabetes. And second important example is the if a patient having a history of ulcer. So in that patient, using of glucocorticoids, it's very tricky, and it will further aggravate the ulcer episode, right? So how? Because normally, if you just try to recall, cyclooxygenase pathway is responsible to produce different prostaglandins, and in which we have prostaglandin I2 or prostaglandin E2. These are responsible to produce defensive mechanism, increases the secretion of mucus secretion, right? Decrease HCl production, so it prevents the formation of ulcer. But if a patient is on glucocorticoids inhibit the synthesis of arachidonic acid, and there is no synthesis of prostaglandins, right? So what will happen when there is no control through prostaglandin I2 and prostaglandin E2, which is produced from the arachidonic acid pathway through cyclooxygenase pathway, cyclooxygenase enzyme. So increased production of HCl, decreased mucus secretion, so increased chances of ulcer. Okay, glucocorticoids also increases uric acid excretion. So what will happen if a patient having a history of gout? So that may lead to a problem. And when there is excessive excretion, so what will happen? Increased urinary calcium excretion, which may lead to renal stone, osteoporosis, and osteomalacia. And as far as the CNS activities are concerned, if a patient is on glucocorticoids, euphoria, psychosis, or depression. Okay, uses of glucocorticoids. One of the use is as replacement therapy in acute adrenal insufficiency and in Addison's disease. When there is deficiency of uh, adrenocorticoids or in inhibition of secretion of cortisol. So deficiency of glucocorticoids labeled as Addison's disease. This is important, right? So in this situation, we can use glucocorticoids as replacement therapy. Okay, rheumatoid arthritis, not respond to other drugs, right? Bronchial asthma, this is one of the important clinical application where we are using glucocorticoids if patients are not responding with the beta adrenergic agonist drug or mast cell stabilizers. So we can get the control by using glucocorticoids. Why we label not respond to other drugs? Because already we have discussed there are some serious side effects that can occur if a patient is taking glucocorticoids for a prolonged period of time. Okay, we can use in a condition like acute lymphatic leukemia. This is one of the blood disorder, acute hemolytic anemia, thrombocytopenic purpura, ulcerative colitis, systemic lupus erythematosus, SLE, and other collagen diseases. Locally applied in a skin and eye in allergic disorders. in shock, along with anti-tuberculosis of meninges and joints to prevent hydrocephalus, blindness, and stiffness of joints as adjuvant drug, right? In severe infection like typhoid or miliary tuberculosis to help in averting shock and sustaining the patient, while chemotherapeutic agents, they are going to take time to produce its activity. Okay, adverse reactions of glucocorticoids. So in the beginning, I told you, if we know and if we have the clear concept regarding the pharmacological actions of glucocorticoids, so it will be easier for us to differentiate the between therapeutic activity or adverse reactions, right? So diabetes mellitus, one of the adverse reaction of glucocorticoids, and already we have discussed in the pharmacological actions, right? Because glucocorticoids, they are going to produce hyperglycemic state or increase blood sugar level due to process of glycogenolysis or gluconeogenesis. Peptic ulcer. So, if a patient having a history of, there is a chance of perforation of peptic ulcer, right? So, peptic ulcer, perforation of peptic ulcer may take place without its characteristic symptoms. Sodium and water retention, right? So, if a patient having a history of hypertension or congestive heart failure, right? So, use of glucocorticoids, it's alarming, right? So sodium and water retention. So it will lead to hypertension, edema, and hypokalemia. Because glucocorticoids, they promote the reabsorption of sodium and promote the excretion of potassium. So that is why it will lead to, when there is excessive excretion of potassium, it will lead to hypokalemic state. Clear? Iatrogenic Cushing syndrome. What does it mean? Iatrogenic means physician induce. Physician induce. What does it mean? Or drug induce, right? Drug induce. Okay, there is a question that how do glucocorticoid cause peptic ulcer perforation? I think already I have explained it to you, because glucocorticoids, they are going to inhibit the synthesis of arachidonic acid. How? By inhibiting phospholipase A2 enzyme, which is responsible to convert phospholipid into arachidonic acid. And arachidonic acid enter into two pathways. With the help of cyclooxygenase enzyme, enters into the cyclooxygenase pathway, and that will lead to formation of different prostaglandins, prostaglandin E2, prostaglandin I2, right? And there is another pathway that is called leukotriene pathway, right? And responsible to produce different leukotrienes which are involved in allergic disorder. So when we block the synthesis of arachidonic acid, there is no synthesis of prostaglandins, because prostaglandins plays a vital role and involved in different physiological functions of the body, right? So one of the function is to, it prevents the formation of ulcer through which prostaglandin, prostaglandin I2 and prostaglandin E2. Prostaglandin I2 is responsible to decrease secretion of HCl, and at the same time prostaglandin E2 is responsible to enhance the secretion of mucus. So normally this mucosal lining or decrease HCl penetration, so it prevents the formation of ulcer. When we inhibit the synthesis of arachidonic acid due to glucocorticoids, there is no formation of prostaglandin I2 and E2. Ultimately, what will happen? Decrease mucus secretion and increase HCl production. So it will further promote the ulcer. So if a patient already having this problem, so it will be aggravated due to the use of glucocorticoids. Clear? So where we were, iatrogenic Cushing syndrome, that means drug induced, right? And what is this Cushing syndrome? Hypersecretion of cortisol, right? Hypersecretory state. Clear? Because already we have discussed, when there is excessive use, right? So it will lead to increase level of glucocorticoid or hypersecretory state. Addisonian crisis on sudden withdrawal, right? Corticosteroids should be withdrawn gradually, right? So this is one of the important recommendation, and this you must know. If a patient is taking glucocorticoids for a prolonged period of time, so it is advised not to stop the glucocorticoids suddenly. We are going to taper off the dose. We are going to stop the drug gradually, not suddenly, because due to feedback mechanism, it will suppresses the activity of adrenal gland, adrenal insufficiency, right? And adverse reaction, hypercoagulability of the blood is also already we have discussed. Immunosuppression, right? One, in few examples, this immunosuppression is required because we use glucocorticoids in the certain condition as immune where we are required the immunosuppression. One of the important example is the organ transplantation in which we are required the immunosuppressive activity. Number two, in autoimmune disease we are required the immunosuppression. But due to immunosuppression, what can occur? There is increased chances of opportunistic infection, right? So that is why in that context, this immunosuppressive activity is harmful. Okay, masking manifestation of inflammation, spread of infection, and delayed tissue healing, right? Osteoporosis, this already we have discussed, glucocorticoids, they are going to enhance the osteoclastic activity. In osteoclastic activity there is increased bone resorption, right? And inhibit the osteoblastic activity, that is the bone formation activity. So that will lead to weakening of bone, osteoporosis, growth retardation, right? Euphoria, psychosis, or depression may occur. Especially this side effect is very important when we are using glucocorticoids in children, right? Euphoria, psychosis, or depression may occur. These reactions disappear once the drug is withdrawn. Teratogenicity, cataract, glaucoma, and muscle weakness, right? So these are the other side effects that can occur due to the use of glucocorticoids. Drug interaction. This is important. Estrogen may decrease one of the glucocorticoids prednisone clearance. So how? In brackets you can see metabolism. How? Uh, there is a question: how do glucocorticoids? Here already we have explained it. Okay, so there are two phenomena, involved as far as the drug metabolism is concerned. One of the activity is the P450 enzyme inhibition activity, and another activity is the P450 enzyme induction activity, because drugs are metabolized generally due to different enzymes which are present in the liver, right? So, if a patient is glucocorticoids and that patient is already taking another drug, and that drug is responsible to inhibit the drug metabolizing activity due to inhibition of the certain enzymes, so what will happen? The drug which is metabolized due to these enzymes, now that drug is not going to get metabolized. What does it means? Because we have inhibited the activity. So what will happen? Because we know drug metabolism is required for the elimination of drug. When there is no drug metabolism, so ultimately the level of that drug will raise. So this is what happened, because estrogen, they are going to inhibit the enzyme activity which are responsible to metabolize the glucocorticoids. So due to inhibit activity. There is no metabolism of glucocorticoids, so ultimately there is no elimination, so the level of glucocorticoid will raise. Okay, there is another activity, that is P450 enzyme induction activity, in which metabolism is faster, right? Suppose the drug remain for 12 hours. After 12 hours is going to be eliminated due to metabolism, right? But if we enhance the drug enzymes activity which are responsible for the drug metabolism, so increase metabolism, so drug will be eliminated within 6 hours instead of 12 hours. So there is decreased level of drug in the blood due to enzyme induction activity, and we have different drugs. They are going to induce the P450 enzymes involved in different drug metabolism, like phenobarbital, phenytoin, rifampicin, that may increase metabolism of glucocorticoids, right? So if a patient is simultaneously taking drugs having enzyme induction ability, will have to consider the maintenance dose, so we can maintain the glucocorticoids level which are going to be excreted out earlier due to the use of drug which are responsible to induce P450 enzyme activity. Okay, this is another point which is very, very important from the clinical point of view. It will, if a patient is on glucocorticoids, may cause digitalis toxicity secondary to hypokalemia. You know, in which condition we use digitalis. One of the example is the digoxin, because if we say digitalis, we have two compounds, digitoxin or digoxin, but clinically we are using digoxin in the chronic heart failure patient, right? And hypokalemic state may induce the digoxin toxicity or digitalis toxicity. These glucocorticoids, they are also responsible to produce hypokalemia. So if a patient is on digoxin, increased chances of digoxin toxicity. So monitor for hypokalemia with the co-administration of diuretics. You know, this also we have discussed, because loop diuretics or thiazide diuretics, both are responsible to produce hypokalemia. So if a patient is on diuretic and that patient is also on glucocorticoids, so that will lead to marked hypokalemic state. So this will have to keep in our mind, right? Preparations for clinical purposes, synthetic glucocorticoids are used due to their high affinity to the receptors, slowly inactivated, because naturally occurring glucocorticoids, they are rapidly or quickly metabolized. So these synthetic preparations, synthetic glucocorticoids, so these are important points why we prefer to use synthetic glucocorticoids, because they have high affinity to the receptors, slowly inactivated, and little salt and water retention, right? Examples, prednisone and prednisolone, betamethasone, dexamethasone, and most important point, these preparation doesn't have salt retaining action, because okay, generally we say uh, mineralocorticoids, glucocorticoids, but generally even glucocorticoids having salt retaining ability, just like mineralocorticoid activity, right? So these synthetic preparation, they doesn't have salt and water retaining activity. So these preparations, synthetic preparations, they are preferred, right? Beclomethasone inhalation for bronchial asthma, triamcinolone in severe asthma, and locally, especially in intra-articular joints. Now, mineralocorticoids, we have aldosterone, desoxycorticosterone, and fludrocortisone. So, in the beginning, we already discussed about the aldosterone. Aldosterone is a very powerful mineralocorticoids, but it has a weak glucocorticoid activity, right? It releases from the adrenal cortex and is controlled by the renin-angiotensin system. It acts on collecting tubules, causing reabsorption of sodium, bicarbonate, and water. Potassium and hydrogen are lost in the urine. Aldosterone is rapidly inactivated in the liver after oral administration. Aldosterone has a short half-life, around 20 minutes, so used intramuscularly in acute adrenal insufficiency, but it has no place in routine therapeutics. Desoxycorticosterone is the naturally occurring precursor of aldosterone. It has the pure mineralocorticoid activity, and desoxycorticosterone acetate intramuscular, subcutaneous, or subcutaneous pellet implantation is used with cortisol for replacement therapy in Addison disease. Fludrocortisone, it is the only mineralocorticoid given orally, and it has a very great mineralocorticoid plus a significant glucocorticoid activities. It has a long duration of action, and fludrocortisone is preferred in replacement therapy in Addison disease to preserve sodium and treat hypertension, as in case of interstitial nephritis and autonomic neuropathy. Now, adrenocorticosteroid antagonist. Receptor antagonist, spironolactone, it's a competitive antagonist of aldosterone at its receptors. And another example is mifepristone. It's a blocker of glucocorticoids as well as progesterone receptors. It is used in treatment of Cushing syndrome. And synthesis inhibitors, we have metapron, aminoglutamide, and ketoconazole. These drugs inhibit steroid synthesis in the adrenals. They are used in Cushing syndrome and adrenal cancer when surgery is contraindicated, right? Because hypersecurity state, that is called the Cushing syndrome, and deficiency is called Addison disease. So one of the phenomena is to inhibit its synthesis in Cushing syndrome. Metapron inhibits beta hydroxylase enzyme and inhibits glucocorticoid synthesis as well as aldosterone synthesis. Aminoglutamide is used in advanced cancer breast to suppress adrenal secretion of estrogenic steroids, right? So already we have discussed the adrenal cortex, zona glomerulosa, zona uh, fasciculata, zona reticularis. So reticularis is responsible to release androgen and estrogen, right? Formastine, it prevent conversion of androgen to estrogen. It is used in relapsed breast cancer on tamoxifen therapy. Ketoconazole, it is an antifungal, blocks ergosterol synthesis in fungi. It also blocks steroid synthesis in gonads and adrenal cortex. It is used in Cushing syndrome and prostatic cancer. Classification of adrenocorticosteroids: short to medium acting glucocorticoids, hydrocortisone, cortisone, prednisolone, methylprednisolone, and meprednisone. So these are the examples of short to medium. And intermediate acting glucocorticoids, we have triamcinolone and peramethasone and flurprednisolone. Long-acting glucocorticoids, betamethasone, dexamethasone, these two are being used extensively. Mineralocorticoids, we have fludrocortisone and desoxycorticosterone acetate. So this is all about the adrenocorticosteroids. So is there any question? Okay. Okay. Thank you.